Good afternoon and welcome to this exclusive webinar for OHW Plus Premium members. Thank you all for registering and taking the time to join us today, and of course for supporting OHW Plus. I'm delighted to welcome as our speaker today Lesley Macniven, Chair of the Long COVID Support Employment Group. Lesley will be examining the role that occupational health can play in managing and supporting long COVID and how the challenges posed by this condition, or perhaps more accurately, set of conditions, may be a catalyst for greater multidisciplinary working and indeed new conversations around the input and value of occupational health. I'm going to keep this short and we'll let Professor Anne Harris introduce Lesley very shortly. But just, if I may, a reminder that we would love to hear any thoughts or feedback that you have on OHW Plus so that we can continue to improve the site. Please feel free to email or message me or one of the team. I'd also like to draw your attention to the fact the deadline for this year's Occupational Health and Wellbeing Awards has been extended to the 22nd of October. So don't be shy, there's still time to enter. They're free to enter and we'd love to celebrate the great work that you do. There'll be a link appearing shortly on your screen explaining how to enter. On that, and as I'm sure Anne will make clear, there will be time at the end for questions. And please feel free to ask away using the questions function, which you should be able to see on the right. Also, there will be additional CPD activities and resources published on OHW Plus during Lesley's presentation for you to check out and learn from. Finally, this event is one of a series of OHW Plus member webinars taking place during this year. Our next webinar will be in October and will be addressing the challenging issue of supporting dyslexia in the workplace. Full registration details will be published shortly, so please keep an eye out. But now I'll pass you over to Anne and Lesley, what I'm sure will be a fascinating webinar. Thank you.
Thanks, Nick. Well, as Nick has said, today's presenter is Lesley Macniven. She's an expert patient. She's not a clinician, so she's got first-hand experience of what it's like to have long COVID. Just to give you a little bit of flavour of her background, she has a professional background in HR and organisational development. She chairs the Long COVID Support Employment Group, which involves researching the issues, campaigning for multidisciplinary solutions, and then creating guidance with partners. And these partners have included the TUC, SOM, and the CIPD. She's a fellow of the CIPD and runs a consultancy focused primarily on diversity, inclusion, and of course, organisational development. She's worked with a number of clinicians, including Dr. Claire Rayner, and Claire is a consultant occupational physician who also has long COVID, and they built together a Facebook resource group. This has become a campaigning force with, sadly, 43,000 members. That's the 43,000 members who have been impacted by long COVID. So that has now become the charity Long COVID Support, and it is a brilliant resource. Lesley will discuss how positive progress is being made and the potential for transformational change across a number of professions in how we collectively recruit, develop, and just as importantly, retain a healthy workforce with a reinvigorated vision of occupational health at its heart. She'd be really happy to answer any questions that you think of, which you can put in the question box, as Nick mentioned. So it's now my pleasure to hand over to Lesley. So Lesley, over to you.
Thank you, Anne, and thank you, Nick, for inviting me to come along and talk today about the thorny issue that is long COVID. The pandemic has presented a number of challenges, as I'm sure we're all aware 18 months into it. But also, I will argue it's giving us opportunities as well to shift previous paradigms, to jolt us out of complacency and apathy, and be a catalyst for some long overdue changes in how we work within our profession and collaboratively. I love change. I'm slightly unusual sometimes in that way. I've had lots of roles that have involved making change happen. But preferably I like to be in the driving seat, and no one I don't think has felt in the driving seat when it comes to COVID-19. During my career in business, I've been lucky enough to work in risk, in internal audit, and in academia, where interdisciplinary working is absolutely the holy grail. And in the midst of that, I've had 20 years working as an OD consultant for large organizations. I know how challenging it can be to input change. I mean, 50% of change projects don't achieve the objectives they were set out to be. That's my opening gambit when I used to run change management workshops. Equally, trying to do joined up change where you're involving more than one team or profession is even more challenging. So I know that it's not simple to take this catalyst and actually turn it into some change. And specifically, I think where often interdisciplinary working fails is because you're reliant on different teams working together, but there is no third party facilitating. There's no one project managing this change, or there's no one actually picking up the overhead of making it happen. So I don't think it's an easy thing to do, but I have some examples from the last 18 months of how it's actually worked in practice, surprisingly. And it's got a lot to do with having a common purpose. And I think that long COVID and COVID-19 and recovery from the pandemic could be that common purpose for many of us. To be frank, I think long COVID is going to be devastating in its impact, not just for people who contracted COVID-19 and then went on to have ongoing symptoms, but to the businesses who employ them, and to the whole of society if we don't find ways to adequately support the recovery and return to work of many of that talent. So to illustrate the theme of multidisciplinary working, for the next hour I will be wearing several hats. I'm a person living with the lingering effects of a COVID-19 infection, which hit me in March 2020, so that's just over 18 months. I've been a campaigner for rehabilitation, research, and recognition of this as a specific set of conditions since May 2020. And I'm a business professional with 20 years experience in strategic HR, organizational development, and behavior-led change management. So when I got COVID, I very much was sat on my couch watching this pandemic unfold, as we all did, but looking at it very much through the lens of what is this going to mean for business? What is this going to mean for equality? Because a huge passion of mine is greater equality in the workplace. And it became very obvious that existing inequalities were simply being deepened as a result of the pandemic. So I'm just about to advance my slide, just checking I know how to do that. No, that's not working. Ashley, would you mind advancing the slide for me? Thank you. So I was kindly introduced as an expert, a patient expert, and this came from the National Institute for Health Research, who termed the patients who were working with them as experts by experience, and recognised the value that we bring to the table when we're assessing what research needs to happen. Research, greater involvement in public and patient research was definitely one of the quick wins that we made as a support group when people realised that we need to get this right. We don't want to spend 2 years looking in the wrong places. We need to know as much as we can about what long COVID is. And as an OD professional, a big part of my experience was about working with experts to support them to be better leaders. So experts by definition we think of as having all the answers. I don't think at this point in time anybody could claim to have all the answers when it comes to COVID, but as patients, we have a 360-degree perspective on this phenomenon, and we've been identifying it and identifying with it since we contracted it, which for most people has been a long time. And I just wondered on that note if anyone had an idea what percentage of people who are currently experiencing long COVID have experienced that for over a year. So in other words, became infected in the first wave. Any thoughts? What do you think would be a distribution that we would have? Well, the latest ONS statistics that came out in about a week ago talked about just under 1 million people having long COVID, and of that, more than 1/3 had experienced symptoms for over a year. So there is a huge demographic of people who have experienced long COVID symptoms and are falling out of work, because that is a long time to not be in full health. That is a long time to try and stay in the workforce at the same time as recovering from a significant illness that is very poorly understood. So as it happens, I'm the employment group chair for a working group of long COVID support, and all of the people that I have in that team are first waivers. We are definitely experts by experience, and we started off using our expertise to help people by sharing our own experiences in the group, and then that evolved into trying to create change before the next wave, which came later in 2020, so that people getting ill at that point didn't need to go through the confusion, the disbelief, the trauma of basically being asked to stay at home, because unless our lips were turning blue, we were not invited to go to hospital. So there were people essentially writing their wills and having very intimate conversations with loved ones at points in the early hours of the morning when they were awaiting an ambulance, only to be told that one wouldn't be coming during the peak. And that is the type of scenario that we absolutely do not want to get back into as we go towards the winter this year, because traumatic is the word. And that experience has very much driven people to want to make things better. One of the things that we think is part of that is interdisciplinary working, and the team members within our employment group have experience working in occupational therapy. We have Claire Rayner, the occupational physician. We have an occupational psychologist. We have people who've been involved in unions, and people who are very well versed in welfare and benefits because they've worked with the DWP. So we are very much looking at this from a holistic perspective and thinking, how can we collaboratively pull together some kind of solution that would enable people to be better supported? And this is where my entry point is to today's session. I mean, nothing makes me happier than delving into organisational development models and theories of change. But that's the background. The main event for today is really thinking about occupational health. But I would definitely see you as one set of professionals working in a much bigger system. And OD is all about working across an entire system, not just fiddling around in one corner or with one part. And this is what has been seen to be evolving in medical terms. Is initially people thought it was all about our lungs and it was all a respiratory condition. We now know it's a multi-system condition, and the call for long COVID clinics is to reflect the fact that it is difficult for patients to be essentially self-managing their care by having to go to various different appointments with different people and join up what they're being told. What we need to do is try and get better integrated healthcare. We, as Anne said, have had the privilege of working alongside SOM on an ongoing basis. If you wouldn't mind doing the next slide, please, Ashley, thank you. And it's been an absolute revelation to me to understand a bit more about what occupational health actually does. I am an HR practitioner. I was aware that we had an occupational health service that was part of our HR team in the last several roles that I've had, but didn't necessarily come into contact with them a huge amount. But when I looked up a definition of occupational health and I read this particular slide, which was the first one that popped up on Google, that it really struck home that this has to be a pivotal part of post-pandemic recovery. So it's about physical, mental, and social well-being. So again, that holistic perspective. It's about preventing departures from health. So again, I know that there's been amazing work being done to make workplaces safe for people to return to and to keep key workers who have to be in the front line as safe as we could possibly manage. Controlling risks, and obviously the risks have been uncovered as we go, and we now know COVID is airborne. And had I been delivering a guest lecture at Edinburgh University with a mask on to a group of international master students who were also wearing masks, maybe I wouldn't have got COVID in the week before lockdown. Who knows? But we've been working with imperfect information and playing catch up. But the key thing that really struck for me was this idea that occupational health is about the adaptation of work to people. Being part of HR, we write job descriptions, and quite often we kind of look for the person who fits the job description. We're not necessarily looking at the potential of the person who comes to interview and saying, who could we best utilise in our business or in our organisation or in our team? So I think this is a key shift, because I wonder, how accurately does that description reflect your experience of doing occupational health, both pre-pandemic and post-pandemic? Because a key question I posed to myself and to you in coming into this session was, what's actually changed as a result of the pandemic? You will know better than me how you've seen your day job evolving. And all I can say is, from the patient perspective, how occupational health has been extremely helpful for us. So one of the things we're doing at the moment is working with another member of the SOM Long COVID Task Force, Joe Yarker, to look in detail at what interventions and support have effectively enabled people to come back to work. We are also conducting our own survey as well into impacts of long COVID at work, and preliminary results so far show us that roughly 50-50, very roughly 50-50, people are still off work sick and or are back at work, which looks relatively encouraging. But within that, when we actually drill down and look at adjustments to hours worked and to duties performed, most people are having to scale back the work they were doing beforehand. But we definitely see this as encouraging, because in our perspective, being in work, doing something and contributing something is part and parcel of the rehabilitation process. But the biggest barrier that we also experience is a rigidity about allowing people back to the workplace until they are, in inverted quotes, better. And that sees people feeling quite remote and distant from the teams they work in and from their employers. So a big part of how we could be doing better to support people with long COVID is just to change the regularity of communication and the flexibility that's being offered, and crucially, the pace at which people are expected to recover. It's very much a case that the people getting ill with COVID, especially right now when it's attacking the unvaccinated population who are comparatively younger and young people, that chronic ill health is associated with older people, and I would imagine a lot of the work you do is working with people who probably don't have a prognosis of recovery, whereas there is a real desire, hope, and almost a kind of clinging on to this idea that we still have time to get better. We've only been ill for a year. We can see other people who get better. This is something that we can potentially achieve. Okay, can I get the next slide, please? So This is a little illustration that was done by one of our employment group, who goes by the name of Dormouse Diaries. And right at the beginning, we did a campaign, I think it was June 2020, just draw attention to the fact that there were people who'd had COVID for 30, 40 days at that point, when, as it says at the bottom, most people recover within 1 or 2 weeks without needing medical treatment, was the mantra that was being replayed over and over on CNN and BBC News. We didn't experience that, and nobody seemed to be noticing because we were invisible, sat at home. And we kept counting and we kept our log of how things were, how we were getting on, what was helping. And we connected with other people in the Facebook support group in order that we could learn from each other, in order that we could check, look, has anyone else got this weird rash? Which you don't necessarily want to ask in polite company, but the amount of different symptoms, and we were just chatting before we started, when you go in to book a PCR test, which sadly I had to do yesterday because I've got a bit crocked, so apologies, I'm a bit croaky. I had to say if I had one of 3 symptoms. We know there are 200 symptoms, and particularly with Delta, the symptoms people present with are not necessarily the same as they did with the original variant. So we have a lot to learn in terms of not sticking rigidly to this is the way we manage sickness absence. We have this lovely policy we've been working with for the last 15 years. It's been absolutely great. We don't need to change it just because we're in a global pandemic. We have got these 3 symptoms which we recognised, and we actually only added the loss of taste and smell some way into COVID. And again, that was coming through the patient experience, feeding that in. We need to be respecting the fact that we are the experts of our own experience. And the 283 days, the 172 days, when we updated this, it must have been about 9 months in. So maybe towards, I think it was about December, January time, we updated this cartoon. We're now looking at 500 plus days for a third of people who have got long COVID, and people with different sets of symptoms because they've got ill at different points and with different waves. And we may even be seeing people being diagnosed relatively recently getting support, whereas people who weren't diagnosed because they were in the first wave and were at home, not able to be seen by their GP, being told to stay at home and isolate and just rest. You will just get better. There was a phrase being used a lot in Scotland about most people just get better. Well, what about the people that don't just get better? And actually, the most was a fairly vague term, and I'm not sure was exactly accurate in our experience within the support group. So how do we work post-pandemic? I think we need to work in a way that's more flexible and is open to thinking about things differently, and that puts the patient very much at the centre. And sadly, that's not always how people are experiencing the way they're being supported in the workplace. Could I get the next slide, please? So I mentioned the National Institute for Health Research, and we've been doing work with them as patient reviewers, looking at proposals to do research. But they early-ish on, I think it was about October last year, produced a report gathering evidence, the little evidence we had, to see, well, what do we know about long COVID and what do we know about SARS that we can pull in to our practice. And then they updated that subsequently. And the survey that they did to accompany that showed that people were struggling for months. People were struggling. I mean, in the support group yesterday, I couldn't believe the genius of a couple with long COVID who've now started cooking things that they can eat off a piece of kitchen roll, so they don't have to create any dirty dishes to wash and dry and put away. And I thought, necessity is the mother of invention. People are really struggling with very little external support. If you don't have family nearby, people like myself who've got children, it's incredibly difficult to homeschool your children while you're recovering from an illness. And I'm concerned for people without adequate support, as to whether or not they will be as likely to make a full recovery. So there's definitely something around intervention as quickly as possible in order to start the recovery process earlier. Also, as well as the impact on family life, 39% of people were in the position of trying to and struggling to care for their dependents. So that's a big chunk of people. And in the early days, it looked like more women were affected than men. And again, it could be that women were generally the carers during for children who were otherwise would have been at school or nursery during the pandemic. And so if women were struggling to juggle both tasks, I'm not sure how easy or helpful that would be. But the biggest piece for you to be looking at here is 80% of respondents to the NIHR survey said that COVID was affecting their ability to work. So that's if 1 in 10 people get COVID, and that's a fairly conservative estimate, who get COVID, who get long COVID after having COVID, and 80% of them have long COVID and are absent from work for a prolonged period, that is a big chunk of people to suddenly lose out the workforce. And when you notice that, again, whenever you do any surveys and you ask people what employment they have, it's always a majority that are frontline workers. Ironically, the people with the office jobs and the great healthcare cover were generally the ones who were safeguarded by not having to be out in the public, and those that we clapped for on a Thursday night who took the hit and became infected whilst looking after those already ill. Many are now still struggling, and that has to be a huge priority, is to get our healthcare and social care workforce back to a position of health to continue to support us as the pandemic continues. I did get quoted in the SOMS press release talking about trying to get greater access to occupational health for everybody. It makes no sense morally, ethically, or economically that healthcare and other key workers who contracted COVID-19 whilst working during the pandemic's first wave are being discarded, losing their vacation, their livelihood, and their health. They need more than warm words and weekly applause. So this is where occupational health has a massive potential role. And this is also why we're asking for long COVID to eventually be deemed to be an occupational disease. But that is something that will take time, and I'm sure it will happen, but it will take time. So in the meantime, employers need solid guidance and practical support and advice. Occupational health and patient groups have been working together through Society of Occupational Medicine and other interventions to produce guidance and information, such as you will be sent in links after today's session to follow up. And I could go through that with you today, but I kind of want to lift the level of the conversation a little bit, because I think looking at organizational development, it's about fundamentally questioning our approach and why we do what we do. So Simon Sinek is one of the leadership gurus that I enjoy referencing in training that I perform. It's important to stop and think, why are we doing this? So if people are saying, but our sickness absence policy is great, we should just use that. Well, why would you use something that was written before we had a global pandemic? Why would we not review things and maybe adapt our approach post-pandemic? So again, at one of the recent SOM summits, talking about occupational health and how to broaden access and extend coverage and make this a more impactful source of support as a result of the pandemic, putting a spotlight on that key service that was otherwise just a kind of routine service that ran along in the background. You've now got a huge job working with a huge amount of new people with a chronic ill health. This is an opportunity to really think, well, how do we deliver that? And how do we deliver that better? So occupational health in many other countries requires a lot more assessing and a lot less dependence on guidelines. And this is where we definitely see patients struggling at the moment because the assessment is not happening through the NHS, because the NHS, frankly, cannot cope with the level of demands being placed upon it. And quite rightly, the focus in the early days was stay at home and save the NHS, only go to the NHS if it's desperately urgent. But that hasn't helped people with chronic ill health who deserve to be supported at some point in between the various peaks that we've had. So next slide, please. So long COVID support has helped establish this idea that people experience debilitating symptoms for months after infection with SARS-CoV-2. They need investigations, treatment and rehabilitation, as well as support returning to work and education. So we are working across from diagnosis all the way through to being back at work and working back to the level that you're going to be able to return to, which hopefully would be the same as before, but not necessarily. And we've performed a really key function in giving hope to people with long COVID in the absence of that type of support through the NHS. And what we've very much been doing are signposting people to ask for an occupational health referral, to join a union so that they've got somebody to have in the room with them when they have meetings, and to engage with occupational therapists who are great at coming up with practical ideas and examples of how to best manage fatigue, which is a huge issue for not everybody, but a majority of people with long COVID. Fatigue management is a big part of getting back to health. So myself, I'm lucky, my chest symptoms have relatively subsided. I can't go upstairs very easily, but I can sit and I can write again now. I couldn't for a while, and I can speak and I can take part in meetings and add value and do lots of useful things. But if I had to jump on a plane and fly down to London to run a training course 3 times a week, I would simply not be able to do that anymore. So it is about very much looking at how do we tailor support for people based on where they are, what capability they've got to improve, and looking at their job to make that job fit what they can do, rather than expecting everyone to start jumping on planes at 6:40 every morning and travelling across the globe in the midst of a climate change crisis as well. It's the time to rethink how we do work. Next slide, please. So you can obviously come back and look us up at longcovid.org and find out a bit more about it. But we have 40 to 50 people essentially running this organisation. And it's one of the most high-performing organisations I've ever been in. And the amount of impact that we've had, people tell us, is extraordinary, given we've only been operating for just over a year, and given we're in a global pandemic. And what that says to me is, if there's a clear objective and you're clearly motivated, then we can achieve a lot. So hopefully after today's session, you will feel equally motivated to be part of our band of allies who are trying to support those struggling to recover from COVID-19. We found each other online, and we've provided online support across the globe. We have connections to people across the globe, like the Mount Sinai Clinic. We've given support to different task forces through the World Health Organization. There is a huge amount of medical collaboration going on, and that's not what I'm here to talk about today. That would be Claire Rayner, who you would go to or look at some of her past talks, or invite her to come along to look at that. But what we do need to do is to look at how we deliver occupational health support. So next slide, please. And what I would suggest is, rather than taking an expert approach to occupational health in the same way that medics and researchers have confirmed that their work with us has demonstrated that we have earned our place at the table when we're designing services and planning new research, we very much want to work with organisations delivering occupational health. We do that through the Society of Occupational Medicine, but equally, we're, as an employment group, we're happy to connect with organisations who are keen to build on strong foundations around the kind of work that you're doing for people, that you could naturally evolve slightly to incorporate long COVID. And we have a lot to offer in terms of, we have been the ones generating the evidence base in long COVID, sharing practical advice, filling gaps in the formal support system, and campaigning for the last year to 18 months. Next slide, please. So in 2020, our group was literally a lifeline. I mean, you can read comments and others that we post regularly from our review after 1 year. We have had people really struggling and having a huge amount of empathy and support, not just from the moderators of the group, but from the other people in the group. And that has given them a purpose and a hope to keep going. Next slide, please. So last night, I was doing a bit of tweeting, and I was reflecting on what we are seeing within patients' experiences in 2021. And 2021 for us has been absolutely about employment and trying to support people back to employment, or support people to navigate the challenges that they're encountering that are not necessarily around their illness per se, but about how to get into a place where there feels like there's some hope that they can find some support. I know from working in HR, operational HR, were very much colleagues of mine when I was in OD, and we often would have interesting conversations between the kind of change agenda and the operational processes already in place, and having to update those to reflect the aspirations for making the company a bit more agile, or making the company a bit more participative in the style of leadership that it had. And I always do find a lot of operational HR jars with me, because it feels like it kind of drives the show, and anything else that we try to do on change is a kind of bolt-on that doesn't get to challenge some of the systems that are in place that were designed for a different era. And I think that is true of a lot of organisations that have been running for a long time. We need to update a lot of the way in which we manage. So people have said that we've advanced 10 years in terms of the adaptation of tech and home working in the space of a year, because it was a necessity. And I think this could be the same argument for updating the way we manage sickness absence, both from the HR perspective and hopefully with support from occupational health, to challenge HR to perhaps rethink how they do it, because it can feel punitive. And my colleague Jenny, who's part of the group, tweeted last night, "I don't think there is enough awareness of just how stressful it can be taking part in any aspect of the sickness absence process, especially when our financial security, roof over our head, and food on the table all hinges on being able to return to our job." And I just think that sums it up perfectly, that what we really benefit from, if you've got somebody with a process they're trying to follow and not do the wrong thing, and you've got a person who is just desperate and vulnerable, we need some mediator to come in and try and look for the solution, whereby the individual can feel like they're on a path to recovery, and the organisation can feel as if there might be an end in sight. Because beyond doubt, the biggest challenge, people tell me as occupational health specialists, is when managers say, "But how long? When will they be back at work?" And we don't have a crystal ball. So the biggest thing that occupational health people we've been working with have been advocating is, forget 4-week phased returns to work, if that was the norm. It's about being realistic. How long has someone been off already? How quickly are they improving? And it's about taking an approach that is very much around being realistic about what we expect from people. Better to underestimate and overshoot and do better than to push someone too hard and preempt a relapse. Because what again is consistent in people's experience of long COVID, even with different symptoms, is this fact that it's so incredibly hard to gauge how much effort you can expend and how much, when you need to stop, so that you don't have 1 day of really productive activity followed by 4 days in bed recovering. Better to have a half day and a break, a half day and a break, and that way you have the same day's productivity but spaced over 4 days, and you're not feeling you've stepped back 5 paces at the end of the first one. So pacing is key, flexibility is key, and listening to the individual is absolutely key. And again, this was something I retweeted last night, which really spoke to me about the emotional labour that a lot of people who have long COVID are performing on each other to keep us going and keep us afloat. That is something we really need occupational health services, the NHS, not necessarily line managers, although to an extent, line managers are first line managers, need to be the mental health first aiders in any organisation. So looking between the two, there is a connection that, you know, if people are feeling shamed or like they're letting down their colleagues because they can't work, this is the end result, is that we go to bad places, we go to dark places, and nobody wants that. So I am utterly convinced that we would have lost more people to suicide with long COVID had we not had patient groups. And that's just an observation as a moderator, because we get a lot of people presenting in quite a bad way that we have to refer on. So again, this is something that we really need to be closely monitored, because there is nothing more demoralizing than when you have a relapse. And I can only imagine, being self-employed, I haven't been through the returning to work for an employer, so I can only empathize with my previous experiences of when I had ME when I was 19, and I was extremely well supported by my employer at that time, and I then returned to work completely fine and worked for them for another 19 years. And that's my success story. That's my experience of having a chronic condition that took 2 years in total to recover from, but being trusted that I would recover, and trusting myself that I would recover, and doing everything I possibly could to recover. So coming back to this mental health, there are times in the media when, oh, people are just anxious, or, you know, they're just a bit depressed. You know, who wouldn't be depressed? You know, we were all depressed sitting at home. In some ways, when everyone was at home, it was easier because we were all in the same boat. But now that people are going back and we're having Freedom Day and people are returning to work, it can feel like we're being a bit left behind. So there are mental health aspects, but this is a physical illness, as a biomedical illness that impacts on every bodily system, and as such it's incredibly complex. So absolutely we want support for our mental health, but we don't want that to be the thing that people latch onto because it's something that we've got a treatment for in CBT. And the other thing we need to be incredibly careful is we don't do any harm to people. And exercise, there's a hugely contested graded exercise approach that has largely been discounted, that NICE are currently reviewing in relation to MECFS, which lots of people would love to get us doing. And I experienced physio myself through a long COVID clinic, where they were delighted when I forgot and overdid it, because, great, you didn't stop yourself from walking up a flight of stairs. And I was like, yeah, but I was walking upstairs to do a supermarket shop for my family for the week, and I couldn't complete the supermarket shop because my chest hurt and I had to go home early. So, you know, there's a lot of, have you tried yoga? Have you tried this? And with respect, a lot of patients are very well educated and informed. We would like you to ask us what we have tried, and then to look at, well, how about adaptations? What have you tried to be able to? So again, somebody yesterday in a conversation I was having on the Facebook support group was waxing lyrical about the benefits of having one of those stools that you lean on, that you perch on. And she said that the difference that made was enormous. And, you know, I know people who've got mobility scooters, and, you know, we all fantasize about having kind of aids that suddenly, you know, open up possibilities of what we can actually use our energy for. And what else we're talking about is energy limiting conditions. So we have still got capability in many areas, but what we don't often know is, prior to going back to work, our cognitive abilities, what we can and can't do. And so assessment on a cognitive kind of level could be incredibly helpful, and it's not something that people are generally getting access to at the moment until such times as they go back to work. Next slide, please. So Our values were quite obvious to us when we started to formalise as a growing organisation and now a charity. And the values are basically what you see as the defining characteristics of an organisational culture. And in my 20 years working in large organisations, my task in evolving culture was often to get from a purely task focus to a more balanced task and people focus. And so it's no surprise that the first values that we started off with in our Facebook group was to be very much peer led. We have people doing different roles, but it's very flat, where we're not hierarchical, and we all contribute the bit that makes sense for us to contribute. It's very much about being inclusive, no one left behind. So we are very focused on the first waivers who could easily get forgotten about and just be discarded. It has to be collaborative, and that move to becoming much more partner orientated and working effectively with other organisations like SOM. But equally, it became obvious that as well as looking after the people, we thought if we just draw attention to what's happening, somebody will go, oh, that's really bad. We must come along and put some resource into that, and we must get some help for you. And rather naively, even though I've worked in very political organisations for a long time, I kind of thought, yeah, of course, it's a no-brainer. If people are ill and they're key workers, you're going to support them to get better. But we've had to make a really clear business case and be very professional, fact-based, evidence-informed and knowledgeable about the win-win that we're going for. This is not just about being nice to people who are having a hard time. This is genuinely about looking at workforce health and well-being, which absolutely is within your remit. We're incredibly driven. Because we just do not want to see this happen to other people, and we're dependable. We are ill, but I was crocked yesterday, and Nick and Ashley and Anne were all, put your health first, don't worry if you can't do it, we can step in, we've got plan B. And so there was absolutely zero pressure on me, but I wanted to do this because I want the opportunity to talk to you about some of these things that I think are really important to have a conversation about. So if you can think about the organizations you work with, what are their values, and to what extent do they have these inclusive, collaborative, compassionate values? Because there has been a shift in society towards a much more community focused kind of, we're all in it together, which I really hope we can keep, because it's obvious that the organizations that can do this successfully outperform those that are very much work people hard, and once you've got as much as you can out of them, just chuck them out and find a replacement. That is not 21st century leadership and management. Next slide, please.
Lesley,
We're going to have to stop, aren't we?
To the end, because we need to take some questions.
Sure. So our vision is to be understood, to be partners, and to make sure that we are getting the support we need. Next slide. And OD and occupational health, I think, has an opportunity to really think strategically about how we deliver that support, taking on board what patients can tell us, working with organisations like Long COVID Support and others, and some who have developed guidance and expertise in this, but to definitely look at how occupational health and Long COVID Support can collaborate alongside HR, and perhaps combined support HR. I'm speaking at the CIPD's Wellbeing Conference in December, so I'll be doing a plea to my colleagues in HR to seize this opportunity to do a lot of the change stuff we've all wanted to do for so long. This is our opportunity, and I'm sure there will be people in the room today who are occupational health practitioners who would love to evolve and develop the way you are able to practice occupational health, and for this to be seen as a real investment in people, not as an expense, as part of the burden of having people who are sick. Anybody could get COVID, anyone could get long COVID. This is not something that is unusual. We have to adapt our approach accordingly. And I'll stop there.
Brilliant. Thank you so much, Lesley. That was really informative. The thing that really hit me was your comment about individuals who were very sick, rang for an ambulance, waiting for the ambulance to come and writing their wills, and then being told, the ambulance ain't going to come. And that must have been so frightening for those people. Could you go right to the beginning? There was a question which I'll probably come back to about the definition of occupational health. But while you're finding that, a comment from Mark: should the role of occupational health in a COVID-coated, complex and certainly uncertain world in managing sickness absence be one of facilitating the assessments through a multi-stroke interdisciplinary team, as much of this is about function, both mental and physical, and the need to assess occasional rehab needs. So just to encapsulate that, 'cause it's a big chunk to try and concentrate on. It's about, do we need to change the way that we do assessments, and should we be focusing very much on the function of both mental and physical aspects?
Yeah, 100%. I think I would imagine that the perspectives that we're coming at this from are similar, and the patients are just beyond impatience at how long we've waited to be assessed. There needs to be another route. So that's my lateral brain is saying, well, if this route isn't working, how do we go round it? You know, how do we go over it? What's another avenue to take? So when, as I say, when I saw occupational health definition, I thought, oh, this is the solution. And when I started working closely with a couple of occupational therapists, who, whenever I say anything, Kirsty always says, oh, Lesley, have you tried doing this? And I'm like, that's a brilliant idea. Why didn't I think of that? So I do think facilitating is exactly the right verb. And again, employers have a lot to gain from retaining talented staff. I know how much it is to replace staff, and I was given a team to retain people in a large FTSE 100 company as head of talent, because we know how much it costs to go to the market and replace them if they decide to leave. So we were trying to retain people, develop people, and have a succession plan in place. So where you have skilled skilled workers, as many people with long COVID are, there's a real vested interest in investing in their recovery. So if you can pay for some straightforward assessments, if you can get that through your employer assistance program or whatever occupational health provision you have already purchased for your workforce, why on earth would you not do that? So there has to be greater use made of occupational health in the way it's used. So it's not just about doing a quick report and saying this person will be back to work in 3 months. It's about, well, what can we do to help that person get back sooner? But it's also looking at things like occupational therapy and related interventions that could be brought in. And again, we are, in the employment group, we are multidisciplinary. And as we get better, we are effectively forming a consultancy where we can design and deliver materials that we can, train other people to use, or we can even do training delivery ourselves. But, we are clearly not going to be the only people in the world delivering that level of support. This is about asking people to think about doing things differently, and we are trying to get the ball rolling.
Thank you. I'm mindful that the symptoms of long COVID are just so diverse, and what one person may experience might not be the same experience as somebody else. However, two common ones that seem to be applicable across the board are things like brain fog and also the extreme exhaustion that many people are talking about. How do you manage that yourself? Are there any tips you would give that we could think about in relation to advising employees that we might be seeing as a referral?
Yeah, I think patients are quite resourceful. I was writing a book about gender inequality in the workplace before I got COVID, and my dream publisher showed interest in it and asked me to do some more work and send them more information. And I got COVID, and I literally, the last thing I would have been able to do is pick up a manuscript and start redrafting it and doing more, which was rather gutting. But I thought, well, what can I do? And the one job that I continue to do in my portfolio, because the day I caught COVID, I was meant to be in Milton Keynes delivering a training session about diversity and inclusion in a part of England where they had just lost their first patient to COVID-19. So I was slightly relieved that we'd decided to pull that and make it virtual. But that was the day I caught COVID, or I first came down with symptoms, should I say. But what I was able to do was creative writing groups. So I have a creative writing group I've worked with for 3 years. We went on to Zoom. That worked really well. And I thought, there could be something in this. So for over a year now, I've been running creative writing group sessions for people with long COVID, which are using very small, short, easily accessible poems and encouraging people to write in response. We have got everybody in the group has got long COVID, so we don't talk about symptoms and we don't complain about our health. All we do is we process how we're feeling. And through that, people have gone from going, I'm just going to listen today because, my brain fog is terrible, to their brain fog improving and then getting to the point where we are going to, in a week's time, record work that has been produced by that group. Now, these were not necessarily people who wrote before, but they found their way back into reading and into writing and into their creativity by being in a safe space with a few other people and doing some gently guided exercises. So it might be, for some other people, it's painting, or it could be listening to audiobooks. So again, but encouraging people to find something to replace what they can't do is so important. And I genuinely believe that, finding a purpose is really important. And if you can find a way to stay connected and engaged with your team. So, for example, as a physio that we know who is doing a lot of admin for her team, she can't do patient-facing work, but she's offered to help out the team by doing that. It makes her feel better because she's providing input to the team. She's involved in the team conversations about what they're doing, but she's not feeling under pressure to get back to the front line prematurely, because she's actually had 4 failed returns to work because she was desperate to get back. They were desperate to have her, and their expectations were way too high. And I think that's what we've learned, not to be so ambitious. So that would be my tip, is find something that you can do that is baby steps, and keep building and keep building and keep building. And, just help people to feel like they're achieving something, because nobody wants to feel useless.
Mark's just made a really interesting comment. I was so pleased to hear you working with an occupational therapist, or more than one occupational therapist in your group. I believe that we really need more OTs in occupational health. It's a shame that there aren't more. And Mark was saying, why are OTs so sadly missing in the workplace? There are a few employers who do have OTs in their team, but they're few and far between. And I think COVID really has shone a light on how useful having an OT within the team would be.
Absolutely.
I tried to encourage people who were graduating from the OT program when I was at Southbank, and getting them to engage with an occupational health service was so difficult, because they say that's our function, but we're in the hospital setting or in the community setting. They didn't think, actually, I could make a career in the occupational health setting. So, Mark, I would give a thumbs up to that comment.
Yeah. Well, one of the OTs in our group is involved in mentoring students who are studying occupational therapy to, again, help them to understand the long COVID condition, because this is clearly an area of potential interest for them. So there is, everyone's talking about scarcity of skilled workers, from HGV drivers to GPs, because so many people are exiting the health service. We need to be encouraging people to do some new things like occupational therapy to build demand. But the other thing we've chatted a bit about in the past, Dan, again, part of my career in HR and organizational development is coaching. And the idea of coaching is that you don't have all the solutions, but you can help people find their own solutions. So a bit of tweaking people who are workplace coaches to give them some occupational health training, or some, health-based kind of CPD. We could potentially have people, instead of coaching people on being productive and managing their inbox, or managing organizational politics, we could be helping people to think about how to find the way of working that they can manage. I think that wellbeing coaching is something that's been talked about in coaching, and is something that, again, I think there's a huge potential for, because, again, as Mark said, it's facilitating.
And I think occupational health nurses are really well placed to move into that niche area, I'm going to shortly pass over to Nick to wind up, because we are coming to the end of our slot. I think he's got 1 minute left. But the comment that I asked you to put that slide up from was saying, rather than saying the promotion of, etc., should this not be the education of, the rationale being education leads to prevention? I think what that definition actually means is that occupational health is all about promoting, so like a bit of marketing, the maintenance of physical, mental, etc. well-being. And I see as that within that, education is crucial. So
100%.
that's just my comments to the question that was raised about should that be tweaked a bit. I think the two elements are important. But I'm going to pass on to Nick now, because he's got about 30 seconds to wind up. And I'll be calling you later.
I think there's a little bit of flexibility in there, but thank you, Anne. And thank you, Lesley. I thought that was an absolutely fascinating presentation. And so thank you for, well, pulling yourself to your desk and going through it. So I'm really grateful and very much appreciation. I just wanted to add as well, there was a comment during the talk about whether we'll be able to copies of the recording or slides will be available. Short answer, very much yes. The webinar and the slides are going to be available on demand on OHW Plus shortly. So for those who want to revisit it, they can do, and thank you for attending. And obviously for premium members who weren't able to make the event, it will be available that way. But just to say thank you again to Lesley and to Anne, and yes, an amazing and very informative webinar. And we will be back next month in October to talk about dyslexia in the workplace, and very much look forward to seeing you then. Thank you and goodbye.
Thank you, Nick. And I'll call you shortly, Lesley. Okay.
Thank you.
I'll close the meeting.